Hi, I'm Dr. Lisa Brown from UC Davis Health in Sacramento, California. Joining me today are Drs. Brian Louie from Swedish Medical Center in Seattle and Dr. Inderpal Sarkaria from University of Pittsburgh. We're going to be talking to you today about esophageal reflux disease. So I'd like to start off by asking Brian and Inderpal a couple questions. You know, in terms of patient evaluation, the patients come to you with heartburn. How do you counsel that patient? A lot of patients are coming perhaps straight to specialists now and maybe even bypassing their primary care doctor. What kind of questions do you ask those patients, and what kind of myths do you dispel?
So, you know, I think when the patient comes to you with GERD, I think a thorough history is crucial. And then once you get a good sense for what that patient has in terms of symptomatology, whether it's classic symptoms or atypical symptoms, usually I end up heading towards an objective workup, because I think that's one of the keys, because our diagnostic ability as clinicians is at best maybe 70%. And so I tend to favor a standard sort of foregut workup with an upper endoscopy, a pH testing of some sort, high resolution manometry, and I still favor an upper GI esophagogram done on a cine loop.
How about you? What is your standard workup?
I agree. I think Brian really hit on most of the points here. Establishing the anatomy is very important. If you can find a hiatal hernia, for example, in an esophagram, that's a pretty clear-cut reason to have anatomic and physiologic reflux. But really discussing with the patient, number one, the expectations they might have about what they've heard regarding surgery, the true history, as Brian mentioned, elicit those typical symptoms. So you know that if you're going to intervene in this patient, you have a realistic expectation of improving. Ultimately, quality of life is what we're looking for in these patients, and having them relate to you how their quality of life has really been impacted by the disease is important as well.
It's important to get this objective testing, and you mentioned several different types of testing, and I think one that's important is the pH testing. Now, we all know that there's acid reflux and alkaline reflux, and you know, do you have a go-to approach in terms of using a Bravo probe or doing impedance testing, and do the symptoms lead you one way or another?
You want to go first?
Sure. I think for most patients with typical symptoms such as heartburn, a pH Bravo test, capsule and placed by endoscopy over 48 hours off of medication, is probably the gold standard for what we'd like to see to elicit a De-Mystified score and give us an idea if this patient has quantitative reflux of an acid nature. With typical symptoms, that is probably my go-to test 70–80% of the time. If they do not have those typical symptoms, then I do look towards pH impedance testing, looking for non-acid reflux, alkaline reflux, bile reflux, and those patients do tend to have the more atypical type symptoms. So those types of testing can elicit that non-acid reflux, and I think is imperative in those particular cases.
Yeah, I would agree with Netu that, you know, 48-hour wireless Bravo probe testing is probably, off therapy, is probably the gold standard, and it's my go-to choice a good chunk of the time. And if the patient has any symptoms of burning or chest pain, that's my choice. And like Netu as well, I think 24-hour impedance has a role, particularly for people who have, you know, proximal symptoms, cough, throat clearing. And we also have the ResTech probe, the pharyngeal pH probe, for other patients who may not, where impedance may not be totally appropriate. And you know, I think the interpretation of impedance has to be very thoughtfully done by a very good expert, because it's not always correct. And so there's some emerging data coming out of Oregon that suggests that ResTech is potentially probably better than impedance, and so we're still continuing to play with that sort of device as well.
And a further question about this type of testing: do you, for patients especially with atypical symptoms, what do you think about this associated indices, where the patient keeps track of the symptoms that they're having, and what's the symptom-associated probability or the symptom index? Do you use that data? How do you use that data?
Well, I've often wondered if that data is useful and has some applicability clinically. And so several years ago, we had one of the fellows sort of pull all that data out, and we tried to make some sense of it. It probably was one of the messiest data sets we ever encountered and could not make sense of it. And really what ended up coming out of it, just in terms of internal learning in our division, was, if our sense for atypical stuff was correct as surgeons, we were probably as good or better than the symptom index or symptom-associated probability. Now, our GI colleagues, they tend to rely on the symptom-associated probabilities, but I'm not sure those are correct. So I don't know that I find them as useful as I want them to be, and I think there needs to be more work in that area.
In the absence of typical symptoms, you really have to be thoughtful in your discussion with the patient. And this is also, again, couching expectations. We don't know what the atypical symptoms, in the absence of, say, Barrett's or some other objective finding of reflux, that your ability to improve their symptomatology as opposed to creating symptomatology for them is certainly not optimal. So the patient does need to understand, for example, that an anti-reflux operation has a relatively low probability of improving a cough from reflux. So I think it's really a thorough discussion with the patients and understanding what you are trying to achieve with the operation, again, back to quality of life.
And so once you have this objective data and you've taken into consideration the patient's symptoms carefully, especially with the atypical symptoms, how do you counsel that patient? So they're going to ask you about, why can't I just stay on my PPI the rest of my life? Do I really need an operation? They're going to come in with preconceived, I think, notions and preferences. How do you counsel those patients as to what type of therapy may be best for them?
I think that in that situation, again, there are, I think, relatively few hard indications where I would actually tell the patient or recommend strongly for surgery, say history of aspiration, hospitalization, pneumonias recurrent that we think are due to their reflux, usually associated with larger hernias. For patients who simply have symptoms, I generally want to hear the patient tell me that they are considering surgery strongly. And again, this is more of a improvement of quality of life, and it can always wait. There are certainly several other interventions that are the recommended standard of care, weight loss, alteration in diet. But ultimately, if it does come to surgery, there are several considerations when you're counseling the patient as far as what their expectations are. Was that the question? I apologize, Lisa. Can you just ask again?
It was kind of, what are the options in terms of, can they just stay on the PPI for
yes,
long term?
Yeah, PPI certainly, and I think Dr. Louie actually at the recent STS meeting showed a really fantastic slide of some of the concerns regarding PPIs that are emerging, links with potential early dementia, the bioabsorptional implications with calcium loss and frailty of the bones that we're seeing. So there are a lot of concerns, and potentially, increase even in the rates of adenocarcinoma potentially linked to these drugs. So there are an increasing number of patients that are coming in with serious concerns about remaining on these drugs long term, and I think that's where I'm actually seeing a much higher rise in patients seeking surgery.
Yeah, I would agree. I think for me, when the patient's in there, I want to hear that their quality of life is poor despite the PPIs, and then we spend some time outlining the various pros and cons on a spectrum of where PPIs are on one side and how they currently are doing, and we review all these potential side effects, potential complications, and we tell them, look, some of this is correct. We have patients in our practice who have had every one of these, but not everybody gets them. PPIs still, I think, are generally safe, but I think you've got to be careful, and as a primary care physician, and your primary care physician group needs to be watching those things. And then we have discussion about surgery and what the role of surgery might be, and then we give a discussion about the various types of surgery in terms of what's most important to you as a patient. And so we believe in tailored management of acid reflux disease, and so how much reflux control compared to what potential side effects you might get, gas bloat, dysphagia, can't belch, can't vomit with a Nissen, which is what people are very afraid of. And I think you need to alleviate some of those fears, particularly if you know your own data that, look, my rate of this occurring in my practice is very low. People are reassured because they're reading the internet and they think everybody gets it. But that's not true, and I think you need to reassure the patient that Nissen is still a very good operation. And then patients are savvy. They're on the internet. They want to know about magnetic sphincter augmentation or links. They want to know about TIF. They want to know about strata. And I think as a surgeon, you've got to be able to counsel them that these are all the options and what you think the pros and cons of each of those are. And for me, it's a combination of how much reflux control and how do you balance off against side effects. Because the Nissen, which is the gold standard, does produce some side effects. But each of these other modalities, based on objective data, says, look, the reflux control is not quite as good, but the side effect profile is better. And some patients are like, I want that. Some patients are, I want, and they know exactly after the discussion what it is they would like. And it's our job to sort of help them with that, but also have them not make a poor decision that is not going to help them either. So.
And what experience have you had with links? I think that, there are some concerns about having a, metallic foreign object around the distal esophagus, concerns about erosions. From what I've read, the rate is quite low, 0.5%. But this is kind of a newer technology on the market. It hasn't been around a long time. And what are your thoughts on links?
Well, we've been one of the first groups to get on the sort of post-FDA implantation. Netu's group's been there because Dr. Lukatic was implanting as part of the large pivotal trial, and so they have a long experience too. But the erosion rate is actually exceptionally small, and it's a very consistent over time, 0.15%. It's not the 0.5, it's 0.15. And it's different than everything you've ever seen before in terms of size and bandwidth. It's not like a lap band. It's not like the Angel Chick. This is, very different. And that, that rate is still very much in line with other implantable devices. And so, for breast implants, for knees, hips, those are the same sort of explant rates that a lot of those devices are seeing.
I think the LINX is probably one of the most exciting technologies that has come up with in the armamentarium that we have for treating this disease. Certainly, it's a very attractive option to many patients who don't necessarily want to deal with some of the symptomatology that we talked about with the Nissen operation or other anti-reflux procedures. You do have to carefully select these patients still. I don't think we know too much yet about some of the extended indications. So small hiatal hernia, typical symptoms, and in general you want to see manometry with good stripping function of the esophagus. There are certainly groups out there that are extending the indications, and we want to certainly see more evidence and data in the future to see where we may be able to extend the use of this augmentation device, certainly with potentially larger hiatal hernias. But again, for the younger patient with a small hiatal hernia, typical symptoms, many patients are seeking out this operation.
Yeah, no, I would agree. And I think the exciting thing about the LINX device is that the way it's implanted and what it does in terms of physiology, it does do what surgically the principles are. Part of the operation is to restore length of the intra-abdominal esophagus, tighten up the crura, and then have an augmentation of the sphincter. And it does all those things, and there's data that shows that that's correct. And so that's why it's attractive, because other things that have gone by the wayside haven't really adhered to the surgical principles, because we know the barrier is a combination of the lower esophageal sphincter, the diaphragm, all these things mesh together. And this is the one device that does do that. And so I think it's an attractive and exciting device. But like Netu, I think has to be, as you extend these indications out, they're done properly. Otherwise, we're not going to have the outcomes that we think are appropriate.
Right. I'd say similar to Nissen, we don't want to raise a perception or impart a perception that this is a straightforward, simple procedure. By and large, it is. But there are technical details of the operation, avoiding the vagus nerves, et cetera, that still have to be followed. So it's still something that you want to be sure you go to observe someone putting it in, potentially have someone proctor, but straightforward relatively compared to other operations, but you have to pay attention to the technical details so we don't sort of recapitulate the issues we had with Nissen early on with some of the consequences of Nissen that we see.
Absolutely. And Brian and Netu, I want to thank you for your time and sharing your experience with the audience. I think there's a lot of exciting new technology and in the pipeline, and also certainly right now that's available to our patients to improve the quality of life of those with gastroesophageal reflux disease. So thank you.
Thank you.
Thank you.